Before we begin, let us go through and confirm proper setup and configuration of all instruments, and confirm that the patient anatomy is ready for the Medtronic CoreValve system. Make sure the patient's ACT level is greater than or equal to 250 seconds. Confirm that the super stiff guide wire is contoured to the inner cavity of the left ventricle. Confirm that the graduated pigtail catheter is positioned properly in the non-coronary cusp of the aortic root. Confirm that the camera is positioned in the ideal annular viewing plane as predetermined earlier in the procedure. Insert the Medtronic CoreValve R system over the guide wire using the inline sheath or a separate 18 French introducer and advance to the descending aorta while maintaining strict fluoroscopic surveillance of the superstiff guide wire. When crossing the aortic arch, it is critical that the second operator controls the guide wire and prevents it from moving forward. Without proper management, the guide wire will move forward, possibly causing trauma to the left ventricle. Advance the catheter through the native valve. Note, during initial crossing of the valve, it is possible to have an unacceptable drop in systolic pressure. If systolic blood pressure drops below an acceptable level, withdraw the catheter into the ascending aorta and ask the anesthesiologist to increase blood pressure. Position the catheter tip into the LVOT and confirm proper camera angle by visual inspection of the radiopaque marker. If the marker appears as a straight line, proper camera angle is achieved. If it appears as an oval, consider repositioning the camera until orientation lines up with marker. Perform an angiogram. Confirm that the pigtail catheter is still within the non-coronary cusp of the aortic root. At this time, visually identify the distance between the base of the aortic root and inflow edge of the valve frame. Now let's take a look at the crimped valve. Note the dark bands corresponding to frame nodes along the length of the valve. The distance between the inflow edge of the valve and the first band is 6 mm. With an optimal implantation depth of 3 to 5 mm, the target placement of the valve is the highlighted portion of the valve from the midpoint between node 0 and 1 to just below node 1, implanted within the aortic annulus. After valve placement has been established, confirm proper guide wire pressure on the inner wall of the left ventricle cavity. After attaining optimal guide wire position, the second operator should slowly turn the deployment knob to begin to deploy the valve. As the capsule retracts, the valve will remain in the capsule flare portion of the capsule until the capsule flare is retracted beyond the inflow edge of the frame. Be sure to reference the distal edge of the capsule flare to determine how much of the valve has been deployed. If movement is noticed during initial deployment, reposition the valve to the target implantation depth as deployment continues. Perform an angiogram. Valve can either be advanced or withdrawn as long as annular contact has not been made. As the inflow aspect of the valve starts to flare outwards, monitor valve position under fluoroscopy. Once annular contact is made, evaluate valve position relative to the annulus to determine if the valve is in an optimal position. The bioprosthesis can be recaptured and redeployed to achieve a more optimal implant depth at any point before the point of no recapture, indicated when the radiopaque marker band reaches the distal end of the paddle attachment. Turn the deployment knob in the direction opposite the arrows to partially resheath or completely recapture the valve. Once the valve frame is no longer in contact with the native anatomy, it can be repositioned to redeploy. Note, if repositioning due to a pop-out, it is recommended to perform a complete recapture of the valve before recrossing the native valve. The R bioprosthesis can be resheathed or recaptured a total of 3 times. The first 2 times, the bioprosthesis can be repositioned and redeployed to achieve a more optimal valve position. The third time, the valve must be completely recaptured, retrieved from the patient, and replaced with a new valve and delivery system. After valve position is evaluated and adjusted if necessary, continue to deploy past the tactile indicator, a tactile warning occurring around 2/3 deployment that is felt in the delivery system handle to indicate the point of no recapture is approaching. Note, between 1/3 and 2/3 deployment, blood pressure will drop. Once the tactile indicator is reached, it is important to continue to deploy until blood pressure returns to normal parameters. Once pressure returns, but before reaching the point of no recapture, stop deployment and perform an angiogram to assess valve position. Target placement is represented by the highlighted band, representing the target implantation depth of 3 to 5 millimeters, lining up with the annular plane. If satisfied with valve placement, observe the catheter position in the arch to identify the presence of tension in the system. If the position of the catheter is along the inner curvature of the aortic arch, this may indicate the presence of tension in the system that can place an antegrade force on the valve as it is fully deployed. If tension is suspected, relieve the force on the valve by slightly pushing on the catheter just prior to valve release and retracting the guide wire until the distal tip of the delivery catheter centers inside the inflow aspect of the frame. Once tension has been released from the system as needed, turn the deployment knob until both frame paddles separate from the paddle attachment to complete valve deployment. Verify under fluoroscopic guidance that the paddles have completely detached from the paddle attachment and that the catheter tip is centered within the inflow portion of the valve before retrieving the delivery system to the descending aorta. Close the capsule by sliding back the handle trigger while holding the deployment knob stationary, and retract the gray handrest toward the deployment knob until they meet. Release the trigger and listen for an audible click to indicate that the system is locked. Verify that the system is locked by pulling on the deployment knob and tip retrieval mechanism, and verify that the nose cone is not over-captured before withdrawing the system.